I have probably a very easy topic because it's the only one that we will all agree that they don't work, so it's easy to go through this. I don't have any conflict of interest. I found this graphic very interesting because I think it summarizes everything that you're going to find in the literature right now in cardiogenic shock. So we know cardiogenic shock is bad. You have a systemic hypoperfusion and low ventricular systolic and diastolic function. And if it's not recognized and treated, it becomes a spiral that leads to death. So I think that summarizes also the fact that the goals right now are about timely recognition of cardiogenic shock, move the patients to mechanical support as soon as possible, and as the authors say, they minimize inotropes and vasopressors. So as everybody probably think about when I see nurses from the ICU, we don't like to receive these patients in the ICU. 400 inotropes. The nurses don't like all those cables that they need to tangle and untangle. But the reality is we prefer not to get these patients in the ICU. We really are here to make sure that the patient doesn't reach that point, hopefully. And not just because all the cables that the nurses need to untangle, it's because when we look at all the studies done in cardiogenic shock, we can see vasopressors and inotropes really don't show any benefit. It's something shows that the mortality is higher on those patients. So there are several principles that we have to take in account when we are talking about these medications. The first one is one drug can go to different receptors. And not all the receptors are going to give us the desired effects that we want. Also, there may be a curve on the dose response. So when you get certain dose, you're going to have certain effects on some receptors, but not others. As long as you change the dose, the effects are going to be changing. And then we have to deal with the consequences of what we do in life. So one of those is when you use inotropes, and you are looking for something, you have to deal with the hemodynamic consequences of that too, because your body is there to adjust to whatever we are doing. So we may have some effects that we want, but then the body is going to probably have a secondary effects that we don't want. This is a simple graphic just to show that catecholamines, when we are talking about pressors, we have the norepinephrine, as you can see, can go to different receptors, beta 1, beta 2, alpha 1, alpha 2 receptors. And in reality, epinephrine, the effects of the catecholamines, the norepinephrine and epinephrine, are going to be depending mostly on what subclass of receptors are on the different organs. So when we talk about epinephrine and all of these medications, all of them have pretty much the same effect. We are going to see increase in the heart rate and cardiac contractility. In epinephrine at lower doses, higher doses, we're going to see more alpha-1 activity with increase in the vascular resistance. Norepinephrine is a very powerful vasopressor. It's less chronotropic. Sometimes you can see some decrease in the heart rate actually by increasing the blood pressure. Dopamine, I'm not going to talk about the so-called renal dose of dopamine because we know that's a very controversial topic. But intermediate doses can give you some cardiac contractility. Higher doses will help with vasoconstriction. Vasopressin is there to do mostly vasoconstriction. I do pulmonary hypertension, and that's one of the medications that I love the most, but we'll talk about later. Phenylephrine is a pure vasoconstrictor, so you will see some of these patients may have a reflex bradycardia. The problem when you see of these medications is like epinephrine. You have a patient with high and prolonged doses of epinephrine that can cause direct cardiac toxicity. You can see myocardial valve necrosis and myocyte apoptosis. Also, it stimulates glycolysis, so you can see increase in lactate levels, which is going to affect the way that you measure lactate on these patients. But for norepinephrine, you will see similar effects on cardiac myocytes with direct toxicity, apoptosis, and reduced renal and splenic blood flow. Dopamine is causing mostly tachycardia and increased risk of arrhythmias, which is a not desirable effect on a patient with cardiogenic shock already. And vasopressin, as norepinephrine, since it's a potent vasoconstrictor, is going to cause reduced splenic and renal blood flow. phenylephrine also, since it's increasing the vascular resistance, can cause a lot of problems. But what is the evidence in cardiogenic shock? Really, there is not too much. There is some studies with very little amount of patients. This one on epinephrine, comparing norepinephrine and dopamine, was 30 patients, and basically what they found is there is no change in hemodynamic parameters measured at that time in between norepinephrine, dopa, and comparing with epinephrine. But patients that were on norepinephrine have higher heart rate, high risk of arrhythmias, and transient lactic acidosis with inadequate gastric mucosa perfusion causing more GI symptoms. This study didn't take patients that were having cardiogenic shock secondary to acute myocardial infarction. So the next one was 50 patients, and they took patients this time with acute myocardial infarction and cardiogenic shock, and look at epinephrine versus norepinephrine. Again, there was similar effects on blood pressure, cardiac index, but in patients with epinephrine, we have a higher incidence of refractory shock. So when you see the graphics there, you will see the blood pressure was the same. The heart rate on the epinephrine group was higher than the heart rate. That's the bottom left graphic. You see the heart rate was higher on patients with epinephrine, and then what they call refractory shock was also higher on patients with epinephrine. So then they say, okay, epinephrine is out of the picture. What about dopamine versus norepinephrine? And we have the SOP2 trial that most of you know as a randomized multi-center trial on all type of shock. It was almost 1,700 patients, and they compare dopamine versus norepinephrine. When you see 17 of those patients have what was diagnosed as a cardiogenic shock, and when they did the subgroup analysis, there was increased mortality in those patients that were treated with dopamine compared with those that were treated with norepinephrine. And also there was a higher risk of arrhythmias on patients on dopamine compared with the norepinephrine patients. There is also a meta-analysis between dopamine and studies that were done on dopamine and norepinephrine, and norepinephrine had a lower mortality, lower 20-day mortality, and lower risk of arrhythmias compared with dopamine. In terms of phenylephrine vasopressin, there is really not too much. There is a small study done in children between phenylephrine, vasopressin, and epinephrine in pulmonary hypertension. It's just 15 patients there, but the vasopressin was the one that has a consistent, better hemodynamics on these patients, and that's probably where you use it more on patients with RV dysfunction and cardiogenic shock when they come with severe pulmonary hypertension. This is an abstract that was presented in 2018. They took patients that were on cardiogenic shock, that were on inotropes, and they added vasopressin to those patients. And adding vasopressin either with other pressors or inotropes was associated with increased mortality in hospital and 30-day mortality. So inotropes, there are several inotropes there. We have the beta-1 adrenergic agonists like dobutamine, phosphodiesterase 3 like milrinone, and then the calcium sensitizers like levosimendan that our friends from Europe use more than us. For sure, we don't have it here. Dobutamine is very positive inotrope. It has effect on vasodilation by via B2 stimulation. Milrinone, but obviously increases the risk of oxygen demand by the heart, and that's why we use it on a stress test. Milrinone has probably more favorable effects on myocardial oxygen and supply and balance. Again, it's a positive inotrope but produces greater vasodilation. And in terms of pulmonary and the right ventricle decreases more the PVR, has a greater augmentation of the RV ejection fraction, less tachycardia, and fewer arrhythmias than dobutamine. Levosimendan, as I mentioned, is not used in the United States. It's used in Europe and other countries in the rest of the world, I would say, except the United States. It's a positive, has a positive inotropic effect. Technically or theoretically has less arrhythmias because it's not increasing the calcium in the cytosol. It's just increasing the troponin C affinity for calcium, and causes coronary and peripheral vasodilation. And then we have the isoproterenol that we in transplant we use a lot for chronotropic and inotropic effect due to beta adrenergic agonist. The problems, all of them will have, again, problems. The butamine, again, increases the myocardial oxygen consumption. There is a tolerance after a few days that has been reported. And again, you have more arrhythmias on the butamine. And I have seen some patients with eosinophilic myocarditis for the butamine. So you have to be careful with that. Milrinone. The principal problem with milrinone, I will say, is a renal excretion. It's a longer half-life compared with the other inotropes. You can go up to 8 hours if you have renal dysfunction. If the patient is really dry, you can cause a lot of vasodilation, and it's harder because it's going to be in the blood for a longer period of time. Levosimendan will be contraindicated in patients with renal liver impairment, patients with history of torsade de Pont, and patients with severe hypotension and tachycardia because it produces a lot of vasodilation. What about the literature? Really, we have been used milrinone mostly for acute decompensated heart failure with not good outcomes in the long term. An acute exacerbation, which will be mostly what cardiogenic shock leading to heart failure patients. The in-hospital mortality was similar to placebo, and they have more hypotension that require intervention with new atrial arrhythmias. We know already that if you are on nitroglycerin and acetyl, you do better than the butamine or milrinone, maybe because those patients were having a better hemodynamic profile. But nonetheless, when you see milrinone and the butamine in cardiogenic shock, really, there is not too much that we can say that has a great benefit. And when you compare both of them, there is no difference in hemodynamics. Arrhythmias are more common on the butamine. In this study particularly, there was no difference on hypotension between both groups, but hypotension was the most common reason to discontinue for discontinuation of the milrinone. So levosimendan, it has been more used in patients with acute decompensated heart failure, improves with symptoms, but in some studies increase the risk of adverse cardiovascular events. There are some studies looking at patients coming with MI, ST elevation MI that get PCI. Within 24 hours, they were started on levosimendan, and they look at echocardiographic measurements or wall contractility, and there was improvement in contractility on those patients that were using CMO levosimendan. As I mentioned before, there is no increase in arrhythmias, and but on the studies when they show improvement in hemodynamic, that didn't translate on benefits in terms of survival. So based on all of this that I have said, really the guidelines will not give us a clear answer of what is the best one to use. The scientific statement for the American Heart Association last year say, okay, well, maybe norepinephrine is the one that has the better profile in terms of pressors, but please read the last line, says the optimal first-line vasoactive medication remains unclear. And they will give you some suggestions depending on what is the clinical picture, but nobody is going to say for sure this is what you have to use. It's more based on expertise and what you have available. When you go on the European guidelines, they look very complicated there. For ST elevation in cardiogenic shock, you will see that but inotropes are class 2B recommendation as much as vasopressors on patients with a level of evidence C or B. They are in yellow because they are not, they are down on the list from all the things that you have to do first. Again, you'll see here, they will say, please avoid inotropes agents if they are very hypotensive or hypoperfuse because it's a safety concern, so that's a class 3 recommendation. Vasopressors still, again, and based on what we have seen, norepinephrine is the one that they prefer. But again, it's just a class 2B recommendation. So in summary, we don't know what to do with pressors and inotropes. And you are not going to get that from this talk, of course. But the reality is there is no perfect inotrope or vasopressor. You have to overweigh what you want. If you want to increase your cardiac output, then you have to deal with a myocardial increase in the myocardial demand, increase of ischemia, more atrial and ventricular arrhythmias. If you increase your vascular resistance, then you have to deal with the effects on RV afterload, peripheral vasoconstriction, splanchnic vasoconstriction, hypoxia too. The only thing I can say is please use the lowest dose possible for the shortest possible time. So when you start to see you're using more than 1 or 2 inotropes or pressors, that's time to move to something else. In regards of inotropes, there is no randomized control trials that is going to tell us that is what drug is better than the other. But basically it's based on local expertise and what do you have. And that's it. Thank you very much.
Thank you. I'm thinking somebody in the panel has some opinions about vasoactive drugs.
I guess I'll start.
Oh my God, feel it.
I think that was a wonderful presentation and a wonderful review. I think we all live in a world, though, that it's very difficult to purely apply a lot of the published trials that have gained a lot of notoriety. I think those trials are certainly important for recognizing what some of the broader toxicities are in a population and helping to determine what are going to be some of the first go-to type agents. But I think we all have to recognize that patients will respond differently to different agents. I think we all know that based on some of the pharmacology of some of these agents, different patients may require varying amounts of alpha receptor, beta receptor, stimulation to maintain the proper hemodynamic profile. So I think, in an individual patient, it's very difficult to always say, one agent is wrong just on the basis of a trial that was published that showed a negative outcome, with that combination. I think we all need to recognize what the limitations are of applying those studies.
I couldn't agree more. And I think one of the points that you highlighted is that these drugs have dose responses, and in many ways a low dose may almost act as if it's a different drug than a higher dose. And we know that higher doses cause toxicity, but what's challenging is knowing how much is too much and at what point we can expect that safety efficacy profile to change. I know that certainly a lot of the guidelines in our practice is pushing towards mechanical circulatory support. I will point out that the randomized trials for that haven't shown improvements over inotropes. So we can't just throw inotropes out and say, gosh, these are toxic, we should never use them. Obviously, that's not the case either. I think that we certainly have experts here who have published the most important trials. I'd be interested in hearing Dr. DeBacker's opinion.
If I could just say that the problem, and this is much akin to transplant, where everything we use is poisonous. Everything we use in cardiogenic shock has a huge risk profile. Inotropes, devices, every one of these, you can imagine ways that things go bad. So I think what really kills is inaction. You put something on, whether it's an Impella and you don't notice the patient has rust coming out for the urine, or something else and you do and you don't notice that there's a problem. I think any of these is reasonable. Otherwise you would outlaw circular saws because some stupid person will cut their hand off and somebody else actually will make a nice piece of furniture with a circular saw. So I think that it was a very nice review but in the reality is you need all of these. You need inotropes, you need all the devices, and mostly you need serial observation because we're not always right. And I would put my plug in for the groupthink. That really, I think one of the biggest things, and sitting next to Dr. Trani, is the observation that shock teams and really, truly multidisciplinary, not just saying it, but actually living it. The groupthink has always proven to be better than any individual. And being able to phone your friend, whether that's a pharmacist, nurse practitioner, surgeon, really I think is the key to improving survival.
I agree with that. I think we are oversimplifying the things. So we're going to say epinephrine is going to work for every patient, and we are dealing with more complex issues than what we think. And I thank you guys for the SKY paper, which is a good step in the right direction. At least we started to look to the stages in cardiogenic shock. Second part, we have different etiological factors. Patient after acute MI might respond differently than a patient with dilated cardiomyopathy or valvular heart disease. And that we start to think about it. But with the main issue now to say increasing escalating inotropes is a bad thing. that means you are not going to improve survival. And to try to say, change that the paradigm now to say, increasing and escalating inotropes, when you see increase in lactic acid, you are going not to improve, certainly, the outcome of this patient. We have to stop and to think about something different. But what kind of inotropes, I think, we need to rewrite the science and the trials regarding which inotropes is more effective in which group of patients based in which stage in cardiogenic shock. That's something I think in starting a new era in that part.
So let me follow up on that. So it's clear that there's heterogeneity in individual patient responses, and one of the big challenges of the trials is heterogeneous populations that give you a gamish that you can't. But it's a little nihilistic to say, well, you can't really tell what's going to work in any given patient. So now that we're getting a little bit better with subgroups and analysis, do you think it's time for better trials?
Well, I think inclusion criteria is helpful to have, a very clean inclusion criteria. I mean, the cleaner, the better. But we're always looking at, when people are trying to design trials, they always kind of hedge the trial design to ensure that the trial results are going to show something favorable or positive. In doing so, often they eliminate or exclude, patient populations, which are the more likely patient populations that we're going to be encountering in the ICU. So it's always going to be a difficult conundrum when we're really dealing with the most complicated patients. They're never going to be equivalent to the clinical trial population, in my opinion.
One of the factors, before giving you the floor there, I mean, having done one of the trials, I mean, one of the key factors also is to pay attention to the exposure time to the drug and the exposure time to prior drugs before you include your patient. I mean, we have seen several trials where the patient were included after 12 hours, after 24 hours. I mean, if you have received one drug for 24 hours, what else can be done by giving another drug for a few hours? So, I mean, the exposure time to your trial drug is also a very important fact when you look at these different trials. Yes, please.
I want to give a little bit of a different conclusion than what you just said about, the trials. To me, the easiest thing in the world is to design a negative trial. And I feel that that's what has been going on in Europe with balloon pump, and I think we're now going to see ECMO, shock, and these various trials. I think they're going to be negative because their inclusion criteria are way, way too broad. And it does not account for the fact that this is extremely heterogeneous group of patients that are receiving care at different points in time of the shock journey, shall we say, of the patient. And right now, I think the study that's being done most rigorously is the danger shock, the danger shock trial of Impella versus standard of care. And the consequence you pay for doing a really well-controlled, tight trial is that it takes a long time to enroll. But this is what these negative trials are not going to move the bar, because we see now we've got a negative trial on balloon pump. In the United States, balloon pump is still #1. Outside of Germany and Denmark, I think balloon pump is still almost #1. So we have negative trials, but we don't follow the results of those trials. We need to have narrow inclusion criteria to move the bar forward, to have positive results. And you need to take incremental steps. It's going to take decades, but incremental steps to show how to treat this disease. And if we need 5 different trials in different 5 subgroups, that's what we should be doing. But we need positive trials.
My question regarding that is, so you narrow down your population so you get a positive trial, but the instant that trial is released, everyone picks it up for the heterogeneous population that you screened out. And this happens in sepsis, where I work much more, and I'm certain it happens in cardiogenic shock as well. So how do you deal, and you're not the panelist, I'm sorry for asking you, how do you deal with that particular issue?
I'm certainly not an expert clinical trialist, but I would think that ironically the opposite approach could be considered as pragmatic trials. Give the drug to everyone who would be a candidate for the drug, and then look back at who are the patients who seem to benefit. The thing that's ironic here is we're talking about doing a single a single intervention for a heterogeneous group of patients and expecting it to work. Of course, that's not going to work. What we really all do clinically is tailored therapy, individualized therapy, and individualized personalized medicine. That's a hot topic. And the question is how do we actually do that? How do we do that at our clinical trial level? Because that's what we do at a patient level.
Make a conclusion about a clinical trial based on retrospective subgroup identification. This is really a fundamental problem and why we can't move the bar that way. Everything has to be pre-specified, not hypothesis generating. So if you want to do a study and you say we're going to prospectively enroll five subgroups, you have to appropriately power the study for each of those 5 groups, meaning, in essence, you're doing 5 different trials. So we have to get over this problem and accept that we're going to have a positive trial, risk that the results might be extrapolated to other, patients who didn't be included. But I can tell you, for example, the SHOCK 2 trial, which was for AMI shock, is not being applied to patients with decompensated heart failure shock. So that's a little bit of a counterexample that the results of the IVP2 shock trial, which were specifically in AMI, are not, proliferating, into every domain of shock. But that's a risk. But we need positive trials to move forward.
So if I could just mention that one of the whole reasons we designed SCAI classification is to be able to say at time 0, this is what it is. And I would disagree with Dan's point. You don't have to power it for 5 trials. In fact, the risk, it depends. In SCAI A and B, probably the outcome's not so common. Whereas in the very severe, if your intervention works, you may find, I think, probably that nothing works very well in the severe cases, and probably nothing is needed in the very early cases. But I think that one of the key things is, whether it's that or any other classification, account for heterogeneity, own it. Take all the patients and just at time 0, you have to put your poker chip somewhere and say, I think at enrollment this guy is whatever, whether you SCAI or anything else, and then classify the groups after the outcomes.
As long as you pre-specify.
Yes, pre-specify.